Alright, welcome back to the cardiovascular playlist. In the previous video, we're looking at the cardiovascular system examination, and this is a continuation for the pediatrics where we'll be looking at congenital structural lesions. My name is Dr. David, and let's dive into the video. So what are some of the congenital structural lesions that you've heard of? So there are several congenital structural lesions that are there, and the ones we'll discuss include septal defects, vessel abnormalities, valve abnormalities, major structural abnormalities, and failure of transposition. So these are the major classes, and they have the conditions, the different diseases in those categories. For example, the septal defects, which generally just means there's a hole in the heart. It could be a hole between the two atria, or it could be which would be known as atrioseptal defect, or between the two ventricles. It will be called ventricoseptal defect. Or sometimes there's a hole between all four where they all meet at the endocardial cushion. Yeah, so when it comes to vessel abnormalities, we can talk of the transposition of the great arteries, if there's coarctation or narrowing of the aorta, there's pulmonary stenosis where the pulmonary arteries hardens, parted ductus arteriosus, valve abnormalities like tricuspid atresia, where the tricuspid valve fails to develop normally, or aortic stenosis. Major structural abnormalities like tetralogy of Fallot, which is a condition that has a tetralogy, basically four abnormalities. We'll discuss it later in details. Hypoplastic left heart, that's a small heart, or failure of transition, e.g. patent ductus arteriosus, and persistent fetal circulation. So I was just introducing some of these conditions, but we'll discuss them in details in the subsequent slides. So let's get right into it. But first of all, I would like us to discuss the difference between cyanotic and acyanotic heart diseases. What do I mean when I refer to a heart disease as cyanotic? So cyanosis, in general, it's when you have a bluish discoloration of either your skin or your mucous membranes. So if you've ever seen someone in the hospital looking blue, that's what we call cyanosis. So there are some certain cardiac conditions which cause this condition, and it's usually just because there's lack of oxygen flowing into that area that is becoming blue. That is so some conditions that can lead to cyanosis include transposition of the great arteries, tetralogy of Fallot, critical pulmonary stenosis, as well as other complex structural defects. And what is meant by duct-dependent heart disease? Some structural abnormalities of the heart are incompatible with life outside the womb once the ductus arteriosus closes. So let's just go back a little bit. Let me take you through the anatomy of the ductus. In a child, before the child is born, actually, they have what we call this ductus arteriosus, which is a fetal blood vessel that connects the pulmonary artery to the descending aorta, allowing blood to bypass the lungs before birth. That's just because, well, the lungs of the baby in the womb is just immature, and it's still filled with fluid and non-functional, so it cannot maintain proper circulation. So therefore, blood is not oxygenated in the lungs of that particular baby. Because of that, well, the blood is actually shunted from the right ventricle or the pulmonary artery right directly into the aorta. And the ductus arteriosus, it actually closes after birth, usually within 24 to 48 hours, and it's usually due to oxygen. When the baby is able to cry and breathe in some oxygen, it causes closure of this ductus arteriosus, and it forms a structure, a ligament-like structure called the ligamentum arteriosum. But sometimes it fails to close. That's what we call a patent ductus arteriosus. If it remains open, it leads to abnormal blood flow from the aorta back into the pulmonary circulation, causing left to right shunt. It can also be potentially lead to heart failure. And patent ductus arteriosus is more common in preterm infants, that is, babies who are born before their time. And the treatment is usually just we treat them with NSAIDs like indomethacin or ibuprofen to induce the closure, or in some cases surgery is done to actually close this patent ductus arteriosus. So this event is often delayed compared to normal, but inevitably the baby will collapse within the first 2 to 3 weeks of life. Giving oxygen may precipitate or accelerate duct closure. Transposition of the great arteries. Well, the babies usually are cynosed from birth. But for preductal coarctation of the aorta, there is no cyanosis. So let's look at a case. So as a 2-year-old boy noted to have cyanosis. He's not in respiratory distress and has no fever. His mother says he has always looked that color, but has had episodes in the past when he grows pale and quiet during play and has to sit himself down for a while. What do you think is the most likely diagnosis of this child? Well, these symptoms that are being described here are mostly characteristic of what we call tetralogy of Fallot. So tetralogy, a tetra means 4, so it means there are 4 components to this disease, and the 4 components include pulmonary stenosis, right ventricular hypertrophy, perimembranous VSD, and overriding aorta. Here is a diagram depicting the tetralogy of Fallot. So here is a normal. On the left you have the normal heart, and on the right you have a heart that has tetralogy of Fallot. So let us look at the 4 components that they are talking about. The first was pulmonary stenosis. Stenosis, well, it means there is some sort of narrowing of the pulmonary artery. Stenosis, stenose, that's narrowing. So let us look at the pulmonary artery. So where is the pulmonary artery? Here it is, right, in a normal heart. So this is how the pulmonary artery is supposed to look. It's wide enough, to allow blood to move from the right ventricle right into the pulmonary circulation. But now in a heart with tetralogy of Fallot, you see it's narrowed. It's smaller than normal. So it means blood will be struggling to move from the right ventricle into the lungs. And the second component of the tetralogy of Fallot is right ventricular hypertrophy. Hypertrophy means, something is getting enlarged, right? The muscles are getting enlarged. And so let us look at the right ventricle here. So if you look at the muscles here, the normal muscles, and you compare it to these muscles, the muscles are bigger than the one on the left, so they have hypertrophied. That's the second component. The third component is perimembranous VSD, ventricular septal defect. So, which means there is a hole between the 2 ventricles, right? So you see in the normal heart there is, the septum, the normal septum. It's separating the left ventricle from the right ventricle. But now you see in the heart with tetralogy of Fallot, there's a space between these 2 ventricles. It means blood can actually shunt from left to right. It can move. This there's deoxygenated blood here, oxygenated blood, so it means there'll be some sort of a mixture here. So the fourth and final component of the etiology of Fallot is overriding aorta. So let's see what's happening with the aorta here. In the normal heart, you can see that the aorta right there is moving from the left ventricle right on top of the pulmonary artery, and whilst in the heart with etiology of Fallot, what's happening? Do you see any difference? So the difference that is here is you can actually see in the normal heart, the aorta actually arises directly from the left ventricle. Whilst in the heart with etiology of Fallot, the aorta is actually arising from the ventricular septal defect. So it's not coming from the left ventricle, it's coming from, it's attaching to like both the left and the right ventricle, which means blood from both the right and left ventricle will be entering the aorta. So you see, instead of the aorta having only oxygenated blood, it's going to have a combination of both deoxygenated as well as oxygenated blood. That's why the child will have what we call cyanosis. So we've discussed the four main components of the tetralogy of Fallot. So usually it presents in infancy or early childhood. The child may be noted to be dusky from early life, usually increasing over time. Main physical signs are persistent cyanosis and an ejection systolic murmur corresponding to the pulmonary stenosis. Polycythemia occurs. So polycythemia is just when you have like a highly concentrated blood. So you have a lot of red blood cells, and usually how you can notice this on physical examination is when you look at the eyes of the child. So you notice that they're going to be prephoric, or they're going to have very pink, like very pinkish, deep pink conjunctiva. So that's a very useful clue that you can actually use to see if a child has polycythemia. And it's usually because the heart is failing to pump oxygenated blood, as we've already discussed, because the aorta is actually taking both oxygenated and deoxygenated blood, and it's failing to deliver oxygen to tissues. And then the body assumes, I think we're not having enough red blood cells. So, the kidney and, there's increased production of hemopoietin, the hormone that regulates the production of red blood cells, and there's a massive production of red blood cells because the body thinks it doesn't have enough blood. So when all those red blood cells are formed, now there's an increased concentration. That is what's causing the polycythemia. Now the child also suffers from hypercyanotic spells, which may be the presenting feature. And when you take an X-ray of a child with tetralogy of Fallot, there's a classical feature which we call the boat-shaped heart. So as you can see, the outline of the heart right here, you can see it's forming like a boat here. So that's, when you see an X-ray like this, well, think of tetralogy of Fallot. The definitive diagnosis is by echocardiogram, so you have to actually be able to visualize the heart by ultrasound to see the structures where the features we just discussed, the right ventricular hypertrophy, the VSD, and the transposition of the aorta, as well as the pulmonary stenosis. Like the only way you're going to be able to determine that is if you actually visualize them. Do this through ultrasound, that we call it echocardiogram. So the definitive treatment is surgical, and medical management will include antibiotic prophylaxis, causes children at risk of developing infections. You also give anticoagulation, well, because these children have a lot of red blood cells, so they're most likely to develop clots. And when these clots develop, they can lead to complications like pulmonary embolism. And usually the classical presenting feature of pulmonary embolism is when there's sudden shortness of breath. You know that there's a clot which has actually obstructed the pulmonary arteries, and this is an emergency. And treatment of the cyanotic spells. So let's discuss the hypercyanotic spells in tetralogy of Fallot. Right ventricular outflow obstruction tends to get worse over time, and acute episodes of pulmonary fundibular spasms occur. Spells are precipitated by activity. For example, when the child is playing or they are feeding, and they may last minutes and then resolve or progress. Presents deepening cyanosis. The children may be agitated, present with shortness of breath and pallor, ultimately floppiness and loss of consciousness, which may damage the brain because the brain is obviously not getting enough oxygen. So this can occur. In older children, they may squat to terminate the spell. And what do you think is the reason why these children like to squat? Now I want to take you back a little bit. So remember when I said one of the key features of tetralogy of Fallot is pulmonary stenosis. Let me just take you back to that diagram. So you see here in the diagram, the pulmonary artery is actually stenosed, or it's narrowed. So blood will find it difficult to actually move from the right ventricle to the pulmonary artery to the lungs to get oxygenated, right? So the easier route is for the blood to just shunt into the aorta. You see, because there's a ventricular septal defect, right? There's a hole in the heart, so the blood will just go into the aorta because it's actually more wider, so it's easier. And so what happens when you squat? When you squat, it's more like you compress the peripheral arteries, like the large arteries, like the femoral artery, you compress them. And when you do that, what it does is it increases the peripheral vascular resistance, or the systemic vascular resistance. And what that does is also, it will mean that there will be high pressure in the aorta, because the aorta has to pump with a greater force to actually overcome that resistance that is created in those peripheral arteries. So when you squat, it means now blood will be finding it difficult to move from the right ventricle into the aorta because it's high pressure. So the blood will still be forced to move through this narrowed pulmonary artery. So therefore, that will actually reduce the impact of what happens in tetralogy of Fallot. So it will reduce the cyanosis. So it will actually improve the oxygenation, in other words. So that's the thing about squatting. Now, the treatment of cyanotic spells, as we've already mentioned, put the child in a squatting or knee to chest position to increase systemic vascular resistance and promote systemic venous return to the heart. Also give oxygen to decrease peripheral pulmonary vasoconstriction, and give analgesia, a strong analgesia like morphine, to decrease release of catecholamines, thereby decrease heart rate and increasing filling time and relaxation of the fundibular spasms. And also give IV fluid bolus to improve right ventricular preload. So that is the treatment of tetralogy of Fallot. The cyanotic spells. Alright, now let's take a look at Another case. This is a 7-year-old girl who comes with a 1-week history of progressive breathlessness and a cough. On examination, she has signs of heart failure. She is not pale or cyanosed. What may be the congenital cause of heart failure in this girl? So the congenital lesions which may give cardiac failure include ventricular septal defects, atrial septal defects, patent ductus septoiosis, and coarctation of the aorta. So first of all, let us look at ventricular septal defects. So as we already described them, it's where you have a hole between the two ventricles, right? And this is the commonest cause of heart failure in infancy. But the bigger the hole, the quieter the murmur, and harsh pansystolic murmur loudest at the left lower sternal edge. So it may be surprising because if you're examining a patient and you're hearing a very, very loud murmur, you'd think, oh, maybe they have a very big hole in their heart. But that's not the case. Because when you have a big hole between the two ventricles, it means the blood will just be flowing smoothly. Like it's not facing any resistance. But now, when the hole is smaller, it means there is some sort of a resistance and there will be turbulent flow of blood in the ventricles. So that would be the one that would be causing that harsh pansystolic murmur, which you'll be able to hear at the left lower sternal edge. So this is just a picture depicting the hole between the left ventricle and the right ventricle, where you're seeing there's a left to right shunt of blood. Here is a picture of an X-ray. The first one is showing is a posterior anterior view. The second image is the lateral view. So you can see the increased vascular markings and the lungs are hyperinflated, and there's flattening of the diaphragms. So these features are actually associated with pulmonary hypertension because of the shunting of blood, which is forcing itself into the pulmonary artery. So that's what is creating pulmonary hypertension. 60% of VSDs will close spontaneously, some never close and may require surgery. However, you can also use medical treatment where you just treat heart failure, or I'll discuss heart failure in details in another lecture. Also, you can give antibiotic prophylaxis because sometimes patients with these conditions are actually at increased risk of developing infective endocarditis. The second condition we're looking at is atrial septal defects. So basically, it's just a hole between the two atria, and most children will be asymptomatic, so they won't show any signs or symptoms. But murmurs is one of the murmur that you hear in atrial septal defect is one of increased blood flow through the pulmonary valve, i.e. an ejection systolic murmur loudest in the pulmonary area. So let me show you an image. Let me explain what I meant by that. So when you have a hole between the two atria, usually the atria areas of low pressure compared to the ventricles. So you won't really be able to hear much as when blood is moving from the left atrium to the right atrium. And it's moving from the left to the right because the left atrium usually is of higher pressure, so blood will move from higher pressure to low pressure. And when this happens, it means now there's an increased overall pressure in the right side of the heart, right? This blood is going into the right ventricle, so blood is, there's an increased preload here. And all this blood, where is it going to go? Well, it's trying to force itself into the pulmonary artery. And when it's forcing itself into the pulmonary artery, it has to pass this the pulmonary valves, and when it does that, that's what creates the murmur when the blood hits the pulmonary valves. So you're gonna hear this crescendo, decrescendo murmur because it's an ejection. The blood is trying to eject itself into the pulmonary artery. And another classical finding of ASD is that it's also associated with a persistent splitting of the S2 heart sound, because I said S2 is created by closure of the pulmonary as well as aortic valves. So when blood is forcing itself into the pulmonary artery, it also creates this persistent splitting of the S2 heart sound. On a chest X-ray, what you can note is a big heart with large pulmonary artery, pulmonary peripheral, and a small aorta. And treatment is surgical, but medical management would be the same as that of ASD. Now let's go into patent ductus arteriosus, which is mostly happens in premature infants because their lungs are not really developed. And as I already explained, what a patent ductus arteriosus is when that connection between the right ventricle and the aorta, which bypasses the lungs, that connection persists. So meaning there will be a mixture of blood. So reversed flow compared to in utero means blood in the aorta diverted to the pulmonary circulation. And the murmur that you're going to hear in hepatic ductus arteriosus is a very classical machinery murmur, which you can hear just below the left clavicle. Coarctation of the aorta. This is a narrowing at a specific point in the aorta, usually before the point at which the ductus arteriosus joins. Therefore presents when the duct closes, which with a collapsed baby and heart failure may have reduced or absent femoral passes, systolic murmur. So as you can see, the aorta right here, this is the normal aorta, it's just small, and when you look at the heart with coarctation of the aorta, you see this kind of constricted area, so there will be limited blood flow. So it depends on where the coarctation is. If it's happening proximal to the heart, if it's actually here, the coarctation is here, it means it's going to affect all the branches of the arteries on the other side. And sometimes you might have absent femoral pulses, or they might just be reduced. That's why on examination you actually compare the radial and the femoral pulses to see if they are the same or if the femoral pulse is reduced, because that could be indicative of coarctation. But sometimes this condition is it's asymptomatic, and some patients may not realize this until adulthood, and it might just be a coincidental finding maybe during examination. They might actually be able to live normal lives without even realizing they have this condition. And treatment is surgical. Medical management, same as for VSD and ASD. And so for that patient now, we're talking about a cardiac echo reveals no evidence of congenital lesion. What may be the acquired causes of heart failure in that girl? So we'll discuss now other conditions like rheumatic heart disease, cardiomyopathy, myocarditis, and bacterial endocarditis. Alright, so let's start with rheumatic heart disease. Rheumatic heart disease is caused by an episode or episodes of acute rheumatic fever leading to endocardium inflammation. It mainly affects the mitral and aortic valves. Inflammation settles with scarring, fibrosis, and deformity of the valve, which may lead to heart failure over time. So in this condition, usually when you have a child who maybe has a classical history of a cough, and this cough usually is due to group B beta hemolytic streptococcus, and so it's not the the infection itself that causes rheumatic heart disease, but then it's the inflammation that comes in due uh, to the healing process. So it causes the scarring, fibrosis over time. So the most common presentation in rheumatic heart disease is mitral regurgitation. So during systole, blood goes backwards through the incompetent valve from the left ventricle to the left atrium and the pulmonary veins. So this reduces the cardiac output and eventually leads to pulmonary edema because blood is back into the lungs. So and there's pulmonary hypertension there, so most of the blood will start leaking into the pulmonary capillaries, creating pulmonary edema. The left ventricle hypertrophies to compensate for this. Symptoms may take long to develop. Patients are easily fatigued and breathless as heart failure develops. The second acquired conditions are cardiomyopathy and myocarditis. These two are actually difficult to differentiate, but cardiomyopathy is a weakened heart muscle, commonly with dilation, may be idiopathic or related to underlying metabolic or connective tissue disorder. Whilst myocarditis, whenever you hear the word itis, is an inflammation. So there's an inflammatory process of heart muscle commonly following a viral illness. So with as I've already said, with cardiomyopathy, you have it's a chronic structural disease which could be genetic or idiopathic, but it's not caused by inflammation, whilst myocarditis is caused by inflammation. They can present at any age with heart failure, poor perfusion, and often mitral regurgitation murmur. This fourth acquired condition is bacterial endocarditis, which occurs in children with congenital or acquired heart defects, which cause turbulent blood flow, e.g. across the valve. Bacterial vegetations form on damaged endothelium and shed infective emboli. It is part of the differential of a fever in a child with cardiac signs. The onset is sometimes acute with fever, prostration, and heart failure. However, usually onset is insidious with fever, fatigue, loss of appetite, and joint pains. On examination, you're gonna find manifestations of vasculitis as well as immunologic phenomena. So when you examine them, you're going to find variable heart murmur, petechial rash, and the classical signs of splinter hemorrhages, osseous nodes, finger clubbing, conjunctival hemorrhage. They can also have the immunological phenomenon of the rough spots, and other signs like splenomegaly and neurological signs. Let's talk about antibiotic prophylaxis in infective endocarditis. So this antibiotic prophylaxis is used to prevent infective endocarditis. The risk is highest in those lesions producing a high velocity turbulent blood flow, like in VSDs. Antibiotics should be given to children with these heart lesions when they have any form of surgery, whether it's a minor operation or when they have a dental procedure, because when you perform a dental procedure like maybe involving tooth extraction, the bacteria can actually get lodged into the blood vessels, and actually when they reach the heart, they're going to touch the valves and cause infective endocarditis. So we can give antibiotic prophylaxis to prevent that from happening. So for our 7-year-old girl with heart failure, how do we treat her? So the treatment of heart failure, so the first thing you do is reduce the amount of blood that the heart has to pump. The heart is failing, when we talk of heart failure, which I said is a big topic that we'll discuss in a different video on its own. It means the heart is not able to meet the demands of the body's needs. So you need blood supply to all the different parts of the body, but the heart just can't handle that. So you want to treat. The first thing is you want to reduce the amount of blood the heart is pumping. How do you do that? You give diuretics like furosemide, spironolactone, and you don't have to memorize the doses because you can always check in your guidelines how much you should give, and reduce the amount of work. You can give vasodilators like captopril, which is an S inhibitor, but you should be careful because captopril can cause hypotension, particularly in patients with ventricular dysfunction. So you have to measure the blood pressure before introducing captopril. Secondly, you have to make sure the heart is able to pump harder, so you can give digoxin, 10 to 30 micrograms per kg per day, and you can give inotrops like noradrenaline and adrenaline in ICU or HDU. And there's supportive therapy. So tube feeding is helpful in babies if you're feeding difficulties. Dietary advice, e.g. low salt intake, because salt will actually cause fluid retentions. If you don't want that to happen, because you're trying to reduce the volume of blood that the heart has to pump, so you avoid salt. And secondly, you nurse in a sitting position, because usually patients with heart failure, when they're lying down, maybe when there's fluid overload, it actually worsens their shortness of breath. They become breathless when they're lying down. And finally, why might children with untreated VSDs or ASDs eventually turn blue? So I want to take you through a condition known as Eisenmenger syndrome. So when you have atrial septal defects or ventricular septal defects, which are treated, it can cause a chronic increase in pulmonary blood flow, and that will cause irreversible damage of the pulmonary vasculature, which will cause pulmonary hypertension. So eventually, it's like the flow across the hole in the heart reverses, because normally blood is actually flowing from the left to the right, but now the blood is moving from right to the left. So it's deoxygenated blood going into the left ventricle. So it's like the heart is pumping deoxygenated blood into the systemic circulation. You know what that will happen? Well, the child will become blue. They'll become cyanosed because they're receiving deoxygenated blood instead of oxygenated blood. They will have all these other symptoms like polycythemia, etc. And it's now too late to fix the septal defect. You cannot treat Eisenmenger syndrome surgically because it's basically too late. The only things you can do is supportive management. So this is just a picture showing finger clubbing resulting from reversal shunt PDA. So that's it for this video. If you have any questions, any comments, please drop them in the comment section. I appreciate it, and I'll see you in the next video.